Good day, everyone. Thank you for answering the pretest. Welcome to the second part of the pulmonary module. I'm Dr. George Maravillosa and here to discuss pediatric pleural diseases and sleep disorders. For this session, our objectives are as follows: to discuss topics on pleural diseases like effusion and pneumothorax and sleep disorders in children, to show and appreciate different radiologic images of this condition, and to discuss the different diagnostic procedures used in these diseases. Let us begin discussing pleural effusion. Just a quick review about the pleural space, because by now you should have already grasped a good recall of your pulmonary anatomy and physiology. Anatomically, the pleural space is bordered by the parietal and the visceral pleura, which covers the inner surface of the thoracic cavity and envelopes all lung surfaces and fissures respectively. The pleural space is filled by a thin layer of clear, colorless, alkaline pleural fluid, which is important but potential space to prevent friction or contact between the two pleura. Generally, there is a net liquid absorption from the pleural space because absorption pressure is slightly greater than filtration pressure. It is believed that the fluid normally enters the pleural space originating in the capillaries in the parietal pleura. The production rate of pleural fluid is approximately 0.01 to 0.02 ml per kilogram per hour, while the pleural fluid clearance by the lymphatics is reported to be at 0.2 ml per kilogram per hour. So, normally, a 50 kilogram human would have formed pleural fluid of about 15 ml daily. The formation of fluid is greatly affected by Starling's equation of transcapillary exchange, which restricts or controls movement of fluid between pleural capillaries and space. Hence, the parietal pleura plays a vital role in clearing excess pleural fluid. This ability, which can increase up to 30 times, is very crucial to prevent fluid accumulation. Pleurisy is defined as the inflammation of the pleura that is often accompanied by an effusion. The most common cause of pleural effusion in children is still bacterial infections, followed in decreasing order by tuberculosis, heart failure, rheumatologic causes, and malignancy. There are no sex predilection of pleural effusion. Both males and females are equally affected. Inflammatory processes in the pleura are divided in three types. First is your dry or plastic pleurisy or effusion. Second is your serofibrinous or serosanguinous pleurisy or effusion. And third is the purulent pleurisy or effusion. For this session, we will greatly focus on the purulent pleurisy or effusion, but I still advise you to read the other two processes in your Nelson's textbook. The mechanism why pleural effusion can happen is shown in this slide, wherein we can divide this formation process to either increase pleural fluid formation or by decreased pleural fluid absorption. In the increased pleural fluid formation, it can be subdivided into the following. Either there will be an increased interstitial fluid in the lung, such as from the left ventricular failure or pneumonia, increased hydrostatic pressure gradient caused about by right ventricular or left ventricular failure or superior vena cava syndrome. Or there may be an increased capillary permeability coming from a pleural inflammation, or a decreased oncotic pressure brought about by low albumin levels, pulmonary edema, or cases of hemothorax. And finally, a decreased pleural pressure in your space brought about by atelectasis. On the other hand, a decreased pleural fluid absorption is caused by a decreased lymphatic drainage due to an obstructed lymphatics in the parietal pleura, or an elevation of systemic vascular pressure brought about by severe vena cava syndrome and right ventricular failure, or just merely a movement of fluid from the peritoneal space. Initially, pain is felt, especially on deep breathing or coughing, described to be dull. Sometimes there will be referred pain to the shoulder or back. Other signs and symptoms of pleural effusion includes dyspnea, cough, fever, and chest tightness. To severe extent, there will be chest obstructions, tachycardia, orthopnea, and cyanosis. From simple note of dull ache or localized pain on palpation, observing patient to guard his or her respiration, and sometimes a child lies on the affected side. These are the initial physical findings of pleural effusion. Friction rub is appreciated until it progresses to become severe, wherein the patient is very ill-looking. Once effusion progresses, there will be dullness on percussion, decreased or absent breath sound, rapid shallow breathing or increased work of breathing, and chest wall tenderness. Let's go one by one with radiologic findings of pleural effusion. As you can see in the image, there are 3 points to consider describing an effusion. First is there is presence of blunting of the costophrenic angle, shown in image 1. An upright view, approximately of 400 ml volume pleural fluid, is appreciated once the costophrenic angle is blunted. Second is the widened intercostal spaces. And finally, number 3, displacement of the midline structures to the contralateral sides. This manifests as large effusions. This is another patient presenting a large effusion on the right hemithorax. Note the arrow signs pointing to the presence of your meniscus sign. This is another patient presenting a massive pleural effusion on the left, or what we call a total whiteout. Look how thus the massive amount of fluid shifted the heart and the midline structures, such as the tracheal shadow, to the contralateral side. Another important thing to do is by doing lateral decubitus. This is important for you to check the quality and quantity of effusions. It evaluates underlying parenchyma. It also assists in planning investigations or treatment. Doing lateral decubitus, as little as 50 ml of pleural fluid can be detected. A measurement of more than 10 mm from the chest wall is sufficient for thoracentesis. A positive result, such as what is shown in this radiologic image, will show a layering or shifting of fluid on the dependent side. Failure of this feature will suspect a loculated effusion. Another modality of choice is doing chest ultrasound. It detects as little as 5 to 15 ml of fluid. It increases its sensitivity if the fluid is more than 100 ml. It's superior for small and loculated effusions. It differentiates pleural thickening from effusions. It prevents fruitless attempts of diagnostic thoracentesis and CTT insertion. The image shown on the left side shows uncomplicated pleural effusion versus that of the normal ultrasound finding and consolidations or air bronchogram in the image above it. Chest CT scan differentiates pleural fluid from pleural thickening. It identifies focal masses that might be the source of the effusion and differentiates lung abscess from bronchopleural fistula. Your CT scan images on the left shows effusion with the light blue arrows, while the image below is an example of a lung abscess. Next is the diagnostic part. Thoracentesis is still the simple and safe procedure of choice for pleural effusion. It is diagnostic in 75% of cases, but can also be therapeutic to evacuate large amount of fluid. This confirms the need for closed tube insertion and possible surgical drainage. Thoracentesis procedure is done by locating the site of 1 to 2 cm below the onset of dullness to percussion in the mid-axillary line or posterior part. Preferably, we can do this with ultrasound guidance. A chest X-ray should be done after to check for any complications of the procedure. The following are the complications of thoracentesis. There could be bleeding, pneumothorax, rupture of spleen or liver, infection, and pain on the site of injection. While these are the contraindications of doing thoracentesis, if the patient has bleeding diathesis, systemic anticoagulation use, small volume pleural fluid, uncooperative patient, and there is presence of cutaneous disease at the needle entry site. Pleural fluid collected should be examined and classified either as exudate, which is the pleural surface involvement either due to increased capillary permeability for protein or due to lymphatic obstruction, or a transudate wherein it is caused by systemic factors such as those that cause decreased plasma oncotic pressure and elevated hydrostatic pressure in the systemic or pulmonary circulation. This slide shows the Leitz criteria of pleural fluid. It is composed of the three variables such as pleural fluid protein divided by serum protein, which is greater than 0.5, pleural fluid lactate dehydrogenase divided by serum LDH, which is greater than 0.6, and pleural fluid LDH, which is greater than 2/3 of the upper limits of laboratory normal value for serum LDH. This is an important process to identify an exudative type of fluid. Furthermore, pleural fluid classification would show you the difference between transudate and exudate based on these variables. Let's go now to the parapneumonic effusion or empyema. Parapneumonic effusion is any pleural effusion associated with bacterial pneumonia, lung abscess, or bronchiectasis, while empyema is simply described to be as pus in the pleura. There are 3 stages of this process. First is your exudative, followed by fibro-purulent, and organization stage. The first stage is your exudative stage. This stage is described as rapid outpouring of sterile pleural fluid into the pleural space in response to inflammation of the pleura. There is increased permeability of capillaries. The pleural fluid would show a low white blood cell count and LDH. Hence, chest tube insertion is not needed. Give only appropriate antibiotics for this stage. The next stage is your fibro-purulent stage. In this stage, there is already a significant increase in your WBC and LDH counts, while decrease in pleural fluid pH and glucose is also been noted. Here, there will be presence of bacteria and cellular debris and fibrin deposits, hence the tendency to loculate. And finally, the organization stage. This is the last stage of pleural effusion. Here, there will be presence of pleural peel described to be thick and inelastic membrane which causes the lung to be trapped. There will be fibroblast production and lung becomes functionless. This may lead to fistula formation. If the fistula would come into the chest wall, it is termed to be empyema necessitatis. While fistula that is formed into the lungs is what you call your bronchopleural fistula. With regards to etiology, there is markedly difference between the adult and adolescents and children. In children, Staphylococcus aureus, Streptococcus pneumoniae, and Haemophilus influenzae are still the common causes. Management of pleural effusion is still by antibiotics and the use of closed tube drainage. The indications of doing a immediate closed tube insertion would be the presence of frank pus, positive gram stain of the pleural fluid, any parapneumonic effusion with evidence of loculation, the pleural fluid pH is less than 7.1, the pleural fluid glucose is less than 40 grams per deciliter, the pleural fluid LDH is more than 1000, and there is massive effusion associated with sepsis. Appropriate antibiotics must be selected, and the decision whether to initiate chest tube drainage of pleural space should be noted. While if the patient improves rapidly, the indication for CTT removal includes if the drainage is less than 30 to 50 ml per day, the drainage fluid is clear yellow, the patient has clinically improved symptoms, and chest tube ceases to function. While if there will be failure of chest tube insertion, the following might be important thing to do. First is the installation of intrapleural streptokinase, doing an open drainage, or to some extent, an open decortication via video-assisted thoracoscopic surgery or VATS. This is the image or diagram which shows you the time scale of different stages of thoracic empyema and treatment, lifted from a cardiothoracic surgery journal. Look how there will be intertwined of the duration of each stage. And above, you can see what is the recommended approach to be done per stage. Pleural effusion, both parapneumonic effusion and your empyema, has an excellent prognosis once adequate treatment is initiated early. A follow-up pulmonary function studies reveal residual restricted disease, but this is uncommon, especially in children. In summary, we have discussed pleural effusion's recognition through symptomatology and the different diagnostic modalities that was discussed. And finally, we have also mentioned the pleural effusion management, both medical and surgical approach. Thank you.